concentrate a little bit, it can be very helpful for you. For example, I'm talking about the real path. If, for the time being, forget about the pupillary path. If there is a lesion of the right optic disc, there is some lesion, some tumor or anything, and this optic nerve, right optic nerve is damaged. What will be the consequences? What will be the consequences? There will be, here I will draw the lesions. There will be total blindness of the right eye. That's it. Okay. But total blindness of the right eye and no pupillary action when you will show the light on in the right eye. But when you will show the light in the left eye, pupil will constrict. Right? Understood? Because of this consensual innervation. Because optic nerve, the afferent nerve is affected, efferent nerve is intact. So, similarly, uh, if optic chiasma is affected, most commonly it is affected by pituitary adenoma. And pituitary adenoma, this is the optic chiasma. It affects the uh, optic chiasma from inferior side, and on the inferior side are present the fibers which uh, the visual fields are projected oppositely. That is, the temporal retina is projected nasally and the vice versa. And inferiorly, the nasal fibers are present from the both eyes, which are decusated. So they will project the temporal visual field, and the lesion at the optic chiasma will give you bitemporal hemianopia. Okay, because nasal fibers are affected, it will give you bitemporal hemianopia. समझ आ रही है? Okay. Now, if the right optic tract is affected, what will happen? The right temporal fibers are affected, so nasal field will be gone, and nasal fibers of the left eye are affected. So again, uh, the temporal field or the right side of the retina, that will be gone. So it will produce क्या होगा इसमें? It will cause left homonymous hemianopia. Because the temporal fibers of this side and nasal fibers of that side. And as we go far from the optic disc to the real cortex, the tissue, the nerve tissue, they become more and more scattered. And at the optic nerve, they are very compact, and the lesions are very demarcated. As you can see, total blindness, very well demarcated by temporal hemianopia, which you can see on real field examination. But as we go, uh, especially to the lateral genital body and then further away, the fibers become less compacted, and the lesions are not that uh, uh, demarcated as they are in the initial stage. For example, if there is some lesion at the lateral genital body somewhere, it will it can give up many types of defects. For example, it may give you a defect like if these are two eyes, a left supraquadrantropia, but it can give you any defect which may not be explainable. And if you get this defect, or if you get this defect, or this defect on the real fields, you can almost with the certainty tell the where could be the possible lesion. But if there is a problem in the lateral genital body and other structures, it is difficult for you to spot the anatomical site of the lesion. This is what I want. Similarly, if there is some problem in the optic radiation, there will be uh, um, undemarcated lesions and scotomas, and you may not be able to tell the lesion the site, but you can tell that at least it is beyond the lateral genital body. Similarly, when we talk about the real cortex, it is basically supplied by the two main vessels. One is the middle cerebral artery, one is the posterior cerebral artery, and it also sometimes it is macular sparing if there is some cerebrovascular accident or a lesion or in the visual cortex, especially of vascular origin. If the the blood supply which is being supplied to the macula, it is involved, then it will be macular involving. Otherwise, it can be macular sparing. Patient will be blind, but it will be he will be able to see the through the central part. If the macula is involved, he will be blind from the center, but he might be able to see from the peripheral part from some of the real fluids. So these are some very important lesions. In your exam, usually uh, bitemporal hemianopia is very commonly asked, even in FRCS or CPS and all exams. This is very important. Okay, now let's move on to the uh, light reflex. Uh, if this eye is blind for any reason, and we show the light in the right eye, real pathway is actually the pupillary pathway. When we will show the light into the right eye, there will be no pupillary reaction of either eye. Understood? Why? Because there is no the pathway is blocked totally. Afferent pathway is totally damaged. But if you show the light into the left eye, there will be pupillary reaction of both the eyes. That will be because of direct reaction, and will be because of the indirect. After that, are you getting my points? If you
सर अगर राइट की टोटल ब्लाइंडनेस हो तब भी अगर हम लेफ्ट में लाइट
yes,
डालेंगे तो तब भी राइट में हमें
yes,
कंस्ट्रिक्ट होगा
because the right optic nerve, which is afferent and sensory nerve, it is damaged. It has nothing to do with the efferent nerve, which is the third nerve. It has nothing to do with that. So blind eyes pupil will react very briskly, just like the direct reflex. And if the uh, optic asthma or uh, okay, these are I'm just going to the important points. The other important point in pupillary pathway is if there is a lesion of the third nerve here, which is efferent nerve. Third nerve can also be damaged by some space occupying lesions or some vascular lesions like diabetes, or if third nerve is damaged, which is efferent nerve, then what will happen? Whether you show the light in this or that eye, there will be no pupillary reaction in the right eye. But both the pupils will react if you show the light in the right eye if it is normal, if its optic nerve is normal. This is normal. Optic nerve is now normal. Both optic nerves are normal. But right third nerve is damaged. The signals are coming, but from here is the damaged nerve. So how the efferent fibers will go and how the pupil will react? They will not be able to react. But the third nerve of the left eye is intact, so that will react in whichever eye you show the light. Understood? Okay. Now, if there is a lesion at the pretectal nucleus, for example, if this fiber is damaged, that is, it is supplying to the left pretectal nucleus. Okay, then what will happen? When you and there is no other lesion, you will show the light in the right eye. There will be direct pupillary reflex will be intact, isn't it? Because from Edinger Westphal nucleus, the fibers are the impulses are going to the pretectal nucleus, and through third nerve they are passing on. But the fibers which are going to the contralateral pretectal nucleus, they are damaged. So there will be absent consensual reaction in the other eye. Understood? These I am telling you that these important lesions which are clinically present. There is a tumor called pinealoma which usually affects the pretectal nucleus. And similarly, I think these are the basics of real pathway and pupillary pathway. If you have understood what we have learned till now with concept, I feel if any of the lesion is presented to you, you by yourself will be able or should be able to find out the what could be the consequence or what will be the result. So thank you very much.